Good morning, ladies and gentlemen, dear patient, dear colleague. Today we'll have the next lecture. The next lecture in this education program of patient and maybe colleague in neuropelveology. And today I will want to have a talk. My name is Marc Possover, you know that. And today I want to have a talk about what is neuropelveology. It's, in my opinion, very important today to have this talk because neuropelveologists are growing actually like mushroom into the forest. So it's easy to say, I'm a neuropelveologist, I have the proper experience in neuropelveology. So it's becoming more and more difficult for the patient to recognize and to trust somebody, to say, yes, that is really a neuropelveologist, or he's just saying that he is a neuropelveologist. So now, today I want to tell you a little bit who I am. So I am Professor Possover, I'm 61. I feel quite young for all the things I have done, even if 61 is not that young, but it's because I started my medical study with 15. So I became graduate as a doctor in age of 22. And before starting with gynecology, I become a cardiovascular surgeon. And that is really a very important point because when you're doing surgery in the lower pelvis in proximity to the nerve, I mentioned several times that these nerves are hidden deep inside the pelvic cavity behind big vessel, pelvic sidewall vessels. And that is a major risk during neuropelveology procedure to get a lesion of this vessel, and these such kind of bleeding are very, very serious and can even kill the patient if the surgeon is not able to deal with this bleeding. But in neuropelveology, the best way is to avoid the bleeding. And for that, you need an absolute knowledge, not just about the pelvic nerves, but also on the pelvic vessel, to know which vessel is well located inside the pelvic cavity. And that's the reason that why, for me, to be a cardiovascular surgery is really helpful to control a bleeding if I get one, but more to avoid a bleeding by a perfect knowledge of vascular surgery and vascular pelvic neuroanatomy. Then 1990s, I moved to Germany and I start with gynecology. Why? Because that time the program Erasmus started and I had to go to the partner university from the University of Nancy, French, where I made my formation as a cardiovascular surgeon. And then I had to spend 2-3 weeks in gynecology in a university in Germany, in Hamburg. And at that time, during these 2 weeks, something happened. One of the surgeons in the department of gynecology got a lesion of the renal arteria, got a really life-threatening bleeding. And because I was a cardiovascular surgeon and I was sitting in the room, I control the bleeding, I correct the lesion, and I save the lives of the patient. And at that time, my chef in Hamburg proposed me to stay in Germany and to start with my formation as a gynecologist with the word. It's very, very good to have somebody like you in our team with experience in general surgery, visceral surgery, and especially in cardiovascular surgery. Then I moved to Germany, and then from Homburg Saarland, I went to Jena, and then there we built a department for oncology. And as a cardiovascular surgeon, it was easy for me to introduce the laparoscopic surgery within the field of the big vessel. And that's the reason why I start 1994 in the University of Jena with a laparoscopic aortic and pelvic lymphnodectomy. And at the same period, I learned the technique of radical vaginal hysterectomy, what we call the Schauter procedure by Professor d'Argent in Lyon, France. So in Jena, I combine the laparoscopic approach for the removal of the aortic and pelvic lymph node with the radical vaginal hysterectomy. So no need anymore to open the abdomen, no need for a Vertine procedure. And then, because at the same time, the word endometriosis start to grow within the gynecology. But at that time, treatment of endometriosis were always based on hormonal treatment, GnRH, analoga, and so on. And once again, as a cardiovascular surgeon, we experience in visceral surgery. I introduced the laparoscopy in the field of the endometriosis surgery. In 1994, I performed the first laparoscopic rectum resection reanastomosis for rectum endometriosis. And since then, I remember that the colleague always told me, Mr. Possover, it's quite dangerous what you are doing, because at that time, the general surgeon always perform an open surgery and a colostoma. And then as a gynecology, I said, no, we will do it by laparoscopy and without the colostoma. So we had years of fight on one side for the surgeon to be able to do the surgery by laparoscopy, and on the other side, fight with a lot of gynecologists who considered at that time that bowel resection was insane because endometriosis is just a benign disease. Then, during this activity, as an oncologist and surgeon for advanced case in endometriosis, I discovered or recognized very soon that when we are doing this surgery by laparoscopy, we are even more radical than by open surgery. We can go everywhere deep inside the pelvic cavity. And what we were not expected, but what we mentioned, what we recognize is that functional complication after the procedure increase. More and more our patients had difficulty to pee after the procedure, trouble with bowel function, with sexuality. And then I got the idea to use the laparoscopy as a microscope to go there and to try to recognize the small nerve before cutting them. And the problem, you cannot do surgery without cutting anything. You will always cut some nerve because you have nerve everywhere, very, very small nerve. So that is a period where I developed the land technique. That means during the procedure, I brought electricity on nerves in order to recognize their function. And when I saw, I bring electricity on this nerve, and I see that the bladder contract or the bowel contract, then I know it's a motor nerve for the bladder or for the rectum, so don't touch them. And that was the start where, for the nerve sparing technique, I developed for 20, 25 years. And it was, believe me, it was really not easy at that time, because at that time, the morbidity, the complication of term in bladder dysfunction was directly parallel to the quality of your surgery. So at that time, to prove that you was a good surgeon, you had to report at least 30-40% of bladder disorder in your patient after radical surgery. So the introduction of the nerve sparing technique have completely to change the spirit of the surgery, to try to keep the same radicality, because in terms of cancer and endometriosis, we don't want to reduce the radicality of the procedure because we want to avoid recurrence, but at the same time, we wanted to reduce the morbidity of the patient. And then that is exactly the start of the neuropelveology. Start with the nerve sparing, and from step to step, I performed the first laparoscopic pelvic neurosurgery, the first Lyme procedure for pain, for pelvic organ dysfunction, and then for paraplegic. And that is my journey of the last 20-25 years. And because I am the founder of the neuropelveology, it was clear that I had to found the International Society of Neuropelveology, what we call the EISN, and of course, I'm the live chairman of this society. At some point, I recognized that it was not enough just to be myself able to do neuropelveology, but at some point, I understood that I had to teach colleagues, I had to bring neuropelveology to all the colleagues involved in radical pelvic surgery, and not just for nerve sparing, but also for treatment endometriosis of the pelvic nerve and other conditions, because you have to be aware neurologists are not dealing within the pelvic cavity, and neurosurgeons are specialized in surgery in the brain, the spinal cord. Few neurosurgeons are specialized in peripheral neurosurgery, but not in laparoscopic surgery. So there is nobody who performed laparoscopic pelvic neurosurgery. And that's the reason why over the last 20 years, I start with this laparoscopic neurosurgery and start to remove tumor to the nerve, release the nerve from mesh implantation, or to remove some clip on the nerve. And at some point, you will find injured nerve, damaged nerve. And when a nerve is cutted, it's not enough just to release the nerve because it's cutted. And that is the time where I introduce the Lion procedures. That means the technique of laparoscopic implantation of stimulation electrode to pelvic nerve, for example, for recovery of loss function or to treat neuropathic pain. And therefore, of course, because of my 25 years of experience in neuropelveology, I am simply the global leader in neuropelveology. So, what is neuropelveology? Neuropelveology is neurology, within the pelvic cavity. So it deals with all disorder of the bladder, of the rectum, sexual disorder, all refractory pelvic pain, pudendal pain, genital pain, anal pain, pain in the lower back, in the leg, and dysfunction of the leg as well, because the nerve, the sciatic and femoral nerve, which are in charge of the function of the leg, are running through the pelvic cavity. So pelvic issue can induce damage or impair the function of the nerve of the legs. Then the neuropelveology is revolutioning treatment option for many patients suffering from syndrome or pelvic condition unknown causes. Because normally we are able, when we are dealing with pelvic pain, we are always dealing directly with a cause. So you have pain because of endometriosis, because of an inflammation, because of a myoma, but we are not dealing with pain because of the nerve. In fact, if somebody feel pain, it's because the nerve are systematic and always involved. There is no place in the body without any nerve. And pain, what I always said, is not a pathology. It's an information that reach your brain and tell your brain, I have pain. And which organ or what structure in the body brings the information on pain to your brain? That's on the nerve. So even if the cause is not on the nerve, like endometriosis of the sciatic nerve or tumor on the nerve, the cause can be outside the nerve, but induce an irritation of the nerve, like, for example, compression by myoma or by enlarged vessel. And this nerve brings the information to the brain, I have pain. And most of these patients, if not to say all patients with issue of the nerve, when we are not finding really the cause outside the nerve, the patient will end up in the syndrome, in unknown cause for pelvic pain, and mostly in the psychological or in the psychiatric corner. And neuropelveology is a different way of thinking. That means in neuropelveology, the first step is to find out which nerve brings the information to the brain, pain. Secondly, which location within the pelvic cavity, because the pelvic cavity is full of nerve, and some nerve are running over 10 centimeters. So you have to know where is the problem on the path of the nerve from the spinal cord to outside the pelvic cavity. And the first diagnosis in neuropelveology then will be what is the cause, endometriosis, tumor, inflammation, whatever. So the key in neuropelveology is the diagnosis and not the surgical skill of your gynecologist or your neuropelveologist, because to do the surgery, you can train that, you can learn that. But the key is the diagnosis. If you don't know which nerve, which location, and what you have to do before the surgery, to release the nerve, to remove endometriosis, to bring a Lion procedure. So maybe you will do a beautiful video that you will be able to post on Instagram, but you will be not able to help your patient because success of the treatment is directly depending from the diagnosis. And neuropelveology have nothing to do with gynecology. Of course, we are using the laparoscopic approach. Of course, we are using our finger to test the nerve through the vaginal or rectal approach. But the rest, it's a neuropelveology diagnosis. It's a neurologic diagnosis adapted to the pelvic nerve, and it's neurosurgery. It's not gynecology by laparoscopic approach. So to say I'm a great expert in oncology or in endometrial surgery don't mean that you're a neuropelveologist. So what makes the most important, the journey, is, of course, somewhere you have to start. You have to start with a certification, Eisen, from the International Society of Neuropelveology with a level 1, 2, 3. One is how to make the diagnosis. Level 2 is to learn a technique of laparoscopic neurolysis and Lion procedure, but from the theoretical point of view, with a small exercise of dissection on cadaver. It's not a fellowship. You don't learn either to do the surgery or you're not trained in diagnosis. The true expertise comes with hand-on surgical experience and much more with real-world diagnosis practice. And diagnosis in neuropelveology is not performed absorbed in 10 minutes. It's takes 1 to 2 hours per patient in order to get all information, to bring all information together on a line, and then to synthesize all the information to a neurological diagnosis and a cause diagnosis. And then you will be able to define what we have to do, the treatment. So when a neuropelveology even absolves the level 1, 2, and 3, it's like a doctor fresh out of the university. He got the title, you are a doctor, but he's not trained in anything. But is not yet seasoned. So the life of the doctor, the training of a doctor will start after the university. With the university, you just get the theoretical knowledge required to start your training and you get a nice diploma. But the training is the rest of the life of surgeon. And usually said, first we have to learn how to do surgery, then we have to learn when to do surgery. And a very, very important step, the last step, usually in the career of a surgeon, is to learn when to not do surgery. And neuropelveology is not only laparoscopic dissection of the nerve. In some point, you have to say no surgery, because neuropelveology treatment based on medication as well, on Botox, and not just on surgery, on laparoscopic surgery. So the main key point in neuropelveology, the most important, is the experience in the neuropelveology. So once again, not just the certification level 2, level 3 with a beautiful award in your back, but the experience. Surgery, it's in neuropelveology, we are going in area I mentioned, very deep in the pelvis, where my generation for 20 years, our professor, our mentor always advised, never go below the obturator nerve, you will find the death because of the huge vessels. And neuropelveology is always below the obturator nerve. So trust your body, your life, only in neuropelveology with really experience. The diagnosis, from the diagnosis, the success of the treatment will depend directly, because the diagnosis will tell the surgeon or the neuropelveologist what we have to do. And once again, your experience is what distinguishes a true neuropelveology from somebody who call himself I'm a neuropelveology, because it's in and cool to be today a neuropelveology. So the path to become a neuropelveologist, once again, is a certification. A real journey to becoming a neurologist takes years of dedicated praxis. So I'm dealing with neuropelveology since 20 years. And if you're becoming a neuropelveologist, it will be not possible for you to stay as a normal gynecologist. Of course, I'm doing endometriosis surgery for severe infiltration, involvement of the pelvic organ. Of course, I'm doing still some oncology, but 80% of my activity today, it's neuropelveology. Colleagues still have a long road ahead to truly master this specialized field. So it's not just a surgical technique, a see one, do one, teach one. Neuropelveology is a discipline. So as a gynecologist, it took us 5 or 6 years to become a gynecologist. Neuropelveology is much more demanding and difficult. So it will need more than 5 years to everyone, at least 10 years, to really become a true neuropelveologist. And for that, you have to be honest. You have to be honest to our patient. It's not enough to say, oh, I was in a congress, I saw a technique of laparoscopic dissection of the nerve. I'm able to do that. You can trust me, I'm a neuropelveologist. No, that is not so true. We cannot become a neuropelveologist overnight just because it's cool. Our duty as physician is to be honest and transparent with our patient. We are not here to sell false promises, but to offer the best care grounded in real expertise. And upholding the Hippocrates oath means putting patient trust and well-being first and not our person in front. So why you have to trust through neuropelveology? Because in a lot of pelvic neuropathic pain, you have no choice. Neuropelveology is a unique field that offers hope and new possibility for a huge amount of patients. Sometimes patients ask me, but what are the risks of a surgical procedure of the pelvic nerve? Of course, there are risks depending from what we'll find, depending from the skill of the surgeon. But on the other side, most of the patients are coming in my consultation as the last hope, the last option. So if we are not doing anything, which alternatives the patient have? The patient have just the medical treatment, painkillers, an alternative to try to manage to control pelvic neuropathic pain. And painkillers are just treating the symptom. So it's not like an infection. You get antibiotic and after 2 weeks, everything is fine. When you treat a pain symptom without primarily treating the cause, it will be a treatment for the rest of your life. And over time, you will increase the dose of the painkillers because you're becoming dependent. And the higher increased dose, they increase side effect. So it will not help you to recover your normal life. Just the treatment of the cause can do that. And the level of the pelvic nerve, that is exactly the field of the pelvic pelvic neurosurgery or the neuropelveology. So with the right expertise mean first the right diagnosis and then a second adapted proper treatment, then the outcome are life changing. Trust the professional with the most experience and not just with talk and post blogs on the social media and dedication in this highly specialized field. It's a very, very high specialized field. So in conclusion, I am committed as the chairman of the Neuropelveology and the global leader in neuropelveology with the most experience on this field. I am committed to training the next generation of neuropelveologists, and that's the reason why I developed the certification in neuropelveology, level 1, level 2, and level 3, and now why I accept observership in my department in Zurich Colleagues coming for an observership are not allowed to touch the patient to perform surgery on my patient. It's not a fellowship. It's an observership because I'm performing surgery under the Swiss law, and the Swiss law don't allow foreign doctor to perform surgery on Swiss or on patient in Switzerland. And secondly, my patient trusts me. I never will let somebody else doing and taking care of my patient. I do that by myself. However, for now, real expertise remain in the hand of those with the most experience, and we are just few really experienced neuropelveologists. I have the most experience at all. But in the future, it will change, I'm sure, because neuropelveology is becoming more and more enter more and more in the field of pelvic medicine. And we had the Congress of Neuropelveology in Paris last May. We will have the next one in Istanbul 25. So more and more colleagues will enter in the field of the neuropelveology. There is no doubt. And the future will make the difference between those who really want to become a true neuropelveologist and those who want just to have some publicity and to say, I'm a neuropelveologist. Because you deserve the best care, and that comes with honest integrity and years of experience. So I hope it was clear for you. I thank you once again. I thank you very much for your attention. Stay healthy and see you the next time for another topic in patient education in neuropelveology. Thank you very much. Have a good day. Enjoy.